morning everyone. I am Dr. Imelda Jain, Assistant Professor in Cardiac Anesthesiology at UN Mehta Institute of Cardiology and Research Center. Today I will be talking about Acute Respiratory Distress Syndrome. This lecture is in continuation with the series of continuous cardiac education that is going on at our institute. Before starting the topic, briefly I would be talking about the causes and differential diagnosis of ARDS. What is the pathophysiology behind ARDS? What are the clinical manifestations in the patient of ARDS? And what are the evidence-based treatment options? So, to start with, what is ARDS? ARDS is basically a syndrome of respiratory failure symptoms that are characterized by dyspnea, that is difficulty in breathing, fast breathing or tachypnea, hypoxemia, bluish discoloration of skin, that is cyanosis, and difficulty in breathing that typically develop in a patient within a week of an initial insult to the lungs. This results in bilateral chest X-ray infiltrates and white opacities on chest X-ray due to diffuse alveolar damage, which can be caused either by a direct injury to the lungs or due to an indirect damage, usually which is because of a systemic inflammation. The end result of all this is a heavy, non-compliant and stiff lungs. Coming over to the statistics. ARDS was first described in 1967 by Ashbog et al. The annual incidence of ARDS is around 60 patients per 1 lakh. About 20% of ICU patients meet the criteria for ARDS. ARDS is responsible for 26 to 44% of mortality in ICU patients, and mostly 80% of deaths are attributed to non-pulmonary organ failure or sepsis. Which are the patients who are at high risk to develop ARDS? So, these patients would include patients with advanced age, pre-existing organ dysfunction or chronic medical illness. Patients with ARDS from direct lung injury have higher incidence of death than those from non-pulmonary injuries. The first definition of ARDS was given in 1994 by American European Consensus Conference. This definition had 4 features. That is, number 1, the patient should have an acute onset of the respiratory symptoms. The chest X-ray should show bilateral infiltrates, and there should be no clinical evidence of left heart failure. That is, the pulmonary capillary wedge pressure of the patient should be less than 18 millimeters of mercury. Accordingly, when we calculate the PaO2 by FiO2 ratio, they defined that a patient with a PaO2 by FiO2 ratio of less than 300 was termed as acute lung injury, whereas when the PaO2 by FiO2 ratio was less than 200, then the term acute respiratory distress syndrome was given. So, this is the X-ray of a normal patient. To classify for an ARDS, this is the chest X-ray which shows bilateral chest infiltrates. Later on, the Berlin definition of acute respiratory distress syndrome was given in the year 2012. This definition was given by European Society of Intensive Care Medicine with endorsement from American Thoracic Society and Society of Clinical Care Medicine. They had devised 3 mutually exclusive severity categories, that is mild, moderate and severe, and they took into account 4 features, that is timing of onset of symptoms, the chest imaging, origin of edema and the oxygenation of the patients. According to the Berlin definition of acute respiratory distress syndrome, the timing of symptoms should be within 1 week of a known clinical insult or new or worsening respiratory symptoms. The chest imaging should show bilateral opacities which are not fully explained by effusions, lobar or lung collapse or any lung nodules. The origin of edema or the symptoms of respiratory failure should not be fully explained by cardiac failure or fluid overload, and this needs an objective assessment either by echocardiography or by measuring the pulmonary capillary wedge pressures, which should be less than 18 millimeters of mercury. The Berlin definition also divided ARDS into 3 categories depending upon the oxygenation of the patient. These 3 categories were mild, moderate and severe. So, in mild ARDS, the PaO2 by FiO2 ratio of the patient is less than 300 millimeters of mercury but more than 200 millimeters of mercury with a PEEP or CPAP support of more than 5 centimeters of water. In moderate ARDS, the PaO2 by FiO2 ratio should be less than or equal to 200 millimeters of mercury but more than 100 millimeters of mercury with PEEP of more than 5 centimeters of water. And in severe cases of ARDS, the ratio of PaO2 by FiO2 should be less than 100 millimeters of mercury with a PEEP of more than 5 centimeters of water. Now coming over to the causes of ARDS. The causes of ARDS are either direct injury to the lungs or indirect injury to the lungs. The most common cause of ARDS, which is direct injury to the lungs, is pneumonia. This accounts for 35% of the cases of ARDS. This pneumonia can be either a bacterial pneumonia, most commonly a streptococcal pneumonia, or a viral pneumonia as we had seen in the COVID patients, or it could be fungal pneumonia. 26% of patients of ARDS have severe sepsis. Other causes of ARDS are aspiration pneumonitis, which is due to aspiration of the gastric contents. This accounts for around about 15% of the cases. Other include direct injury or contusion trauma to the lungs, which account for 11%. The other causes are due to near drowning, pancreatitis, reperfusion injury to the lungs as in cases of post-bypass surgeries, salicylate and narcotic overdoses, fat or amniotic fluid embolism, smoke or chemical inhalation, as well as transfusion related acute lung injuries. Coming over to the differential diagnosis. The main and the most common differential diagnosis of ARDS is left ventricular failure or volume overload. The other differential diagnoses include mitral stenosis, pulmonary veno-occlusive diseases, lymphatic spread of malignancies, and interstitial or airway diseases, which include hypersensitivity pneumonia, acute eosinophilic pneumonia, and acute interstitial pneumonitis. How does a patient of ARDS present to us? So, the patient of ARDS will usually come to us within 24 to 48 hours of an initial insult or injury. The patient will have symptoms of shortness of breath, very fast or tachypneic breathing, that is respiratory rate of more than 40 per minute, low levels of oxygen due to abnormal ventilation, and symptoms that are related to the underlying cause, for example, shock, sepsis, etc. Other common symptoms that the patient would have will be muscle fatigue, general weakness, low blood pressures, and a dry hacking cough, sometimes along with fever. Coming over to the diagnosis. The first and foremost requirement is getting an arterial blood gas analysis. So, by calculating a PaO2 by FiO2 ratio, this ratio is normally more than 450 in healthy individuals. To define ARDS, this ratio should be less than 300. Then getting a chest X-ray of the patient done, this should show bilateral chest infiltrates. Measuring the pulmonary artery catheter or the pulmonary capillary wedge pressure, this should be less than 18 millimeters of mercury, and a CT scan. Coming over to the pathophysiology of ARDS. In this figure, on the left hand side, you can see a normal alveolus. A normal alveolus normally has type 1 cells and the type 2 cells. The type 1 pneumocytes are normally responsible for the gas exchange across the alveoli, and the type 2 pneumocytes help in production of surfactant. Whenever there occurs a direct or an indirect injury to the alveolus, then the alveolar macrophages get activated, which causes the release of pro-inflammatory cytokines, that is the macrophage activating factors, the TNF alpha and the interleukin B. As a result of this, these cytokines attract neutrophils into the alveolus and the interstitium of the capillaries, which causes a damage to the alveolar capillary membrane. As the alveolar capillary membrane loses its integrity, the interstitium and the alveoli gets filled with some proteinaceous fluid, and the surfactant can no longer support the alveolus to keep them distended. As a result of this, the alveolus gets filled up with the fluid and the pulmonary resistance increases. So, as a result of consequence of lung injury, there occurs impaired gas exchange at the level of the lungs, decreased compliance of the lungs, which finally results in increased pulmonary arterial pressures. Coming over to impaired gas exchange. The impaired gas exchange is basically due to two things. Number one, the ventricular perfusion mismatch and increase in the dead space of the lungs. The ventricular perfusion mismatch is because of filling of alveoli with fluid rather than air. Because of filling of the alveoli with fluid, the shunting in the lungs increases, which causes hypoxemia. Therefore, the deoxygenated blood returns to the left heart, which causes systemic hypoperfusion and finally multi-organ failure. Second is increased dead space. This increase in dead space is at the level of the alveoli as well as increase in dead space of the capillaries. As a result, the ventilation perfusion is mismatched. This impairs the carbon dioxide elimination, resulting in hypercapnia, and this results in high minute ventilation as the patient has tachypnea. The second is decreased compliance of the lungs. This decreased compliance of lungs is the hallmark of ARDS. This is because of the stiffness or poorly or non-aerated lungs. The lungs becomes filled with fluid, so they become stiff or boggy, and this requires a high inspiratory pressures to deliver the tidal volume. The third is increased pulmonary arterial pressures. Increased pulmonary arterial pressures occur in about 25% of patients of ARDS. This is the result of two things. Number one, hypoxemia, and number two, hypercapnia. Both these two things result in pulmonary hypoxic vasoconstriction, resulting in vascular compression or direct occlusion of the pulmonary capillaries, which finally results in right ventricular failure. Coming over to the treatment. The protocols for the treatment of ARDS are given by Acute Respiratory Distress Syndrome Network. This network had started studies from 1995 till 2015. In this, they had conducted 11 studies, out of which 10 were the randomized controlled trials and 1 was an observational study. The most pivotal study was the ARMA study. This network of this ARDS network has given us many studies, according to which there are evidence-based management of ARDS. The evidence-based management of ARDS consists of the following features. Number one, you should treat the underlying cause. The ventilatory management should consist of delivering a low tidal volume, that is a low tidal volume ventilation, using a optimal PEEP, monitoring the airway pressures, conservative fluid management, and reducing the potential complications. The ARMA study that was conducted by Acute Respiratory Distress Syndrome Network had published a study in 2000 in the New England Journal of Medicine, and the hypothesis was that in patients with acute lung injury, ventilation with smaller tidal volumes, that is 6 ml per kg body weight, will result in better clinical outcomes than traditional tidal volumes of 12 ml per kg body weight ventilation. Now, what are the advantages of low tidal volume ventilation? When compared to large tidal volumes, the tidal volumes of 6 ml per kg 6 ml per kg of ideal body weight helps in decreasing the mortality of the patients of ARDS. It increases the number of ventilatory free days and decreased extrapulmonary organ failure. This study also showed that mortality is decreased in low tidal volume groups despite these patients having worse oxygenation, permissive hypercapnia, and lower pH. Why is a low tidal volume ventilation helpful? So, when we see a lung of a patient with ARDS, this lung is affected in a very heterogeneous fashion. So, there would be some normal alveoli, there would be some injured alveoli which can potentially participate in gas exchange, which is susceptible to damage from opening and closing, and there will be some damaged alveoli which are filled with fluid and which will never participate in gas exchange. So, the low tidal volume ventilation is a protective measure which avoids the overdistension of the normal alveoli. This uses a normal tidal volume, that is 4 to 6 ml per kg body weight. It minimizes the airway pressures of the airway and use of the positive end expiratory pressure. When we use a low tidal volume ventilation, it should be kept in mind that no AMBU or Bain ventilation should be given to the patient. The another study that was published by the National Heart, Lung and Blood Institute ARDS Clinical Trial Network, and it was published in the year 2004 in the New England Journal of Medicine. The hypothesis was that in patients with acute lung injury who were ventilated with 6 ml per kg body weight, the higher levels of PEEP will result in better clinical outcomes than lower levels of PEEP. When we see this, the higher levels of PEEP to FiO2, they do not improve the outcomes. However, very high levels of PEEP may have negative impact on the outcomes because they can lead to increased dead space, they can cause increased airway pressure, they can cause decreased venous return, and high PEEP can also result in barotrauma to the patient. So, what is required is an optimal level of PEEP. The optimal level of PEEP is the PEEP which helps to keep the alveoli optimally distended and not over distended. Every patient of ARDS needs an optimal PEEP. The goal of optimal PEEP is to maximize the alveolar recruitment and prevent the cycles of decruitment and recruitment in the lung. So, this is a normal pressure volume curve. This is a sigmoidal curve in which there are 3 zones. Number 1 is the zone of decruitment and atelectasis at lower PEEP levels. On the right hand side is a zone of over distension, which is at very high levels of PEEP, when the alveoli get over distended and the gaseous exchange between the capillaries and the alveoli cannot take place. So, there is a safe window which is at the level of optimal PEEP, where the gaseous exchange takes place. A randomized control trial was again published in the Journal of American Medical Association in the year 2008. This had showed that the ventilation strategy using low tidal volumes, recruitment maneuvers and high positive end expiratory pressures for the patients of ALI and ARDS. In this randomized control trial, 983 patients were taken and they were divided into a control group with ALI protocol, low tidal volume and PEEP, versus an open lung group with low tidal volume, higher PEEP and recruitment maneuvers. In this study, they had found that there was no statistically significant difference in the mortality outcomes of the patient. A next randomized control trial was again published in the year 2008 in Journal of American Medical Association. This was a multi-center randomized control trial in which 767 patients were taken. In this study, a PEEP was set to aim to increase the alveolar recruitment while limiting the hyperinflation. Randomly, the patients were divided into 2 groups. One was a group with moderate PEEP, that is 5 to 9 centimeters of water, whereas the other group had a very high level of PEEP, which helped to reach a plateau pressure of 28 to 30 centimeters of water. In this study, they also found that very high levels of PEEP did not significantly reduce the mortality. However, high levels of PEEP to reach a plateau pressures of 28 to 30 centimeters of mercury improved the lung function and decreased the days of ventilator and organ failure duration. So, when we manage a patient of ARDS, as we increase the FiO2, the PEEP should also be increased. This is a sliding scale which shows the range of PEEP with increasing levels of FiO2. So, when the FiO2 requirement is 0.3, a PEEP of normally 5 should be given to the patient. When the FiO2 is increased to 0.4, the PEEP level should range from 5 to 8. With an FiO2 of 0.5, the PEEP should be in between 8 to 10. At an FiO2 of 0.6, the PEEP should be maintained at 10. At an FiO2 of 0.7, the PEEP should range from 10 to 14 millimeters of mercury. At an FiO2 requirement of 0.8, the PEEP should be around 14. FiO2 of 0.9 would require a PEEP of 14 to 18, and with an FiO2 of 1, that is 100% oxygen, the PEEP should be maintained at 18 to 24. Now, coming over to what are the airway pressures that should be maintained in patients of ARDS. Now, plateau pressure is the most predictive indicator of lung injury in patients of ARDS. The goal of ventilatory management should be to maintain the plateau pressures of less than 30. The lower the plateau pressures, the better is the lung. This plateau pressure helps in decreasing the alveolar overdistension and reduces the risk of lung strain. The tidal volumes in the patients of ARDS should be adjusted to maintain the plateau pressures at a goal of less than 30. However, we can increase the plateau pressures to more than 30 in some cases, like patients with obesity, patients with ascites and patients and pregnant patients. The permissible plateau pressures help us to assess the cause of high plateau pressures in the patients. Whenever the plateau pressures are high, then some of the pathologies should be ruled out. For example, number 1 should be the stiff non-compliant lung, that is the ARDS. Second is heart failure. Third is pneumothorax. Fourth is auto-PEEP when it is generated in the patients. Fifth, mucus plug, endobronchial intubation, that is right main stem intubation. Seventh, compartment syndrome, and in patients with chest wall fat and obesity. This is the graph which shows the difference between the peak inspiratory pressures, the plateau pressures. The peak inspiratory pressure is the pressure at the end of inspiration, which is delivered by the ventilator. This peak inspiratory pressure is the resistance which the mechanical ventilator overcomes because of the alveolar distension and the airway distension. The plateau pressures is the pressure at the end of the inspiration after an inspiratory hold. This plateau pressure is an indication of the alveolar distension, and later on is the PEEP, that is the positive end expiratory pressure in the alveoli, which helps the alveoli to keep them distended. The next study that was given by the National Heart, Lung and Blood Institute ARDS network was the pulmonary artery catheter versus CVP to guide the treatment of acute lung injury. This study was published in the year 2006 in New England Journal of Medicine, and this was known as the FACTT trial. In this study, they had concluded that there is no need for routine use of pulmonary artery catheters in ALI patients, and they supported the use of conservatory strategy fluid management in patients with ALI. The results of this study were that using the data from pulmonary artery catheters compared to that from the central venous catheter did not alter the survival of the patients, did not improve the organ function, and did not change the outcome for patients who entered into shock as compared to those without shock. They also concluded that the use of pulmonary artery catheters resulted in more fatal complications, mostly arrhythmias in the patients. The next study that was published by the National Heart, Lung and Blood Institute ARDS network was in the year 2006, and in this they had compared two fluid management strategies in ALI in patients with acute lung injury. The hypothesis was that diuresis of fluid restriction improves the lung function but could not jeopardize extrapulmonary organ perfusion. The conclusion of this study was that the conservative fluid management protocol improved the lung function and shortened mechanical ventilation times and ICU days without increasing non-pulmonary organ failures. Coming over to the fluid management of patients in ARDS. Increased lung water is the underlying cause of many of the clinical abnormalities in ARDS. Because of increased lung water, these patients have decreased lung compliance, poor gas exchange and atelectasis. Initially, when the patient is in a state of shock, the fluid resuscitation should be done. However, when the condition of shock is resolved, effort should be made to attempt diuresis. The guide to this should be a CVP. So, the goal should be to maintain a CVP of less than 4 centimeters of water. Maintaining a CVP of less than 4 centimeters of water helps to shorten the time of ventilatory days and the ICU length of stay, that is 13 days versus 11 days. Next lung ventilation strategy is the inverse ratio ventilation. Inverse ratio ventilation is when the inspiratory to expiratory ratio of more than 1 is delivered to the patient. This inverse ratio ventilation can be in a pressure control mode or in a volume control mode. By increasing the inspiratory time, the stiff alveoli are open for a particular time period, which helps to improve the oxygenation of the lungs, and decrease expiratory time helps the alveoli not to collapse during the expiration, helps in developing an intrinsic PEEP, and thus helps in reducing the shunting. Therefore, more of the oxygenated blood is returned to the left heart. The inverse ratio ventilation helps in improving the oxygenation by reducing the intrapulmonary shunting, by improving the ventricular ventilation perfusion mismatch, by decreasing the dead space ventilation, by increasing the MAC and the increasing P. However, the inverse ratio ventilation should only be used when there is a very high requirement of FiO2 and very high requirement of PEEP. So, in patients of shock, when you cannot deliver very high PEEP, the inverse ratio ventilation can be used. So, indications of inverse ratio ventilation. The IRV is reserved for severe cases when it is impossible to oxygenate the patient adequately. This treatment involves increasing the amount of time that the ventilator is inspiring versus expiring. Normally, the patients spend more time in exhaling than inhaling. This ratio is 3:1. Increasing the amount of time spent inhaling re-expands more collapsed alveoli than positive pressure alone. However, this is an uncomfortable technique which usually requires sedation and a muscle paralyzing drug that helps the respiratory muscles from resisting the unnatural inverse ratio ventilation. So, whenever you are giving inverse ratio ventilation to the patient should be properly sedated and some paralyzing agent should be used. Next is prone position ventilation. In ARDS, the distribution of lung infiltrates is very non-uniform. When the patient is in a prone position, this helps in improving the oxygenation by relieving the areas of atelectasis and improving the perfusion. So, the ventilation perfusion mismatch is decreased. The prone position ventilation therefore helps in improving the ventilation perfusion in previously atelectatic areas, thereby helping in uniform distribution. This was first described by Lam et al. The prone position ventilation should be for at least 6 hours per day. The prone position ventilation also helps in decreasing the right ventricular enlargement and a significant reduction in septal dyskinesia after prone positioning after 18 hours. This was first described by Villiard et al. In the year 2007. However, prone position ventilation does not help in decreasing the mortality of the patient. One of the most famous trials, that is the ProSEVA trial, which involves prone position ventilation, and it was published in Academic Department of Critical Care. In this, 466 patients with severe ARDS were enrolled and patients with prone position versus supine position were taken into consideration. According to this trial, the prone position patients were associated with improved mortality. After 28 days, the mortality of the patient had decreased to 16% from 33%, and the 90-day decrease in the mortality was from 41% to 24%. The patient with prone position also had less evidence of cardiac arrest. However, there was no difference in complications due to ARDS. Coming over to the use of corticosteroids in ARDS. The use of corticosteroid is still a controversial topic in ARDS. What happens is, when we use steroids, they cause suppression of inflammation during the fibroproliferative phase of ARDS. The initial regime consists of using 2 mg per kg of methylprednisolone, and after 3 to 5 days of response, the response normally comes after 3 to 5 days of use of steroids. In 1 to 2 weeks, the dose can be tapered to 0.5 to 1 milligram per kg. This was first described by Meduri et al. However, the ARDS network had a Lazarus study which demonstrated that the use of corticosteroids is not efficacious in ARDS. This study was published in the year 2006, and this had depicted that there was no benefit of corticosteroids on the survival of the patients. In this study, they had hypothesized that when they had concluded that when the corticosteroids were used within 2 weeks of onset of ARDS, they were associated with significant increase in the mortality rate as compared to the placebo group. Coming over to the use of nitric oxide in the treatment of ARDS. Nitric oxide is potentially a selective pulmonary vasodilator. It rapidly binds to the hemoglobin, which prevents its systemic effects. It should increase the perfusion of better ventilated areas. However, many studies have been conducted and they show that there is no positive effect of use of nitric oxide. Use of surfactant therapy. To date, no prospective randomized control trials have been shown to significantly decrease the mortality, mortality benefit of use of surfactant in ARDS. Intravenous use of N-acetylcysteine may increase the lung surfactant. Coming over to future treatment options. There are many anti-inflammatory strategies which can include use of antioxidant therapy like N-acetylcysteine, procysteine, oxygen-free radicals or the precursors of glutathione, prostaglandin agonists or inhibitors like prostaglandin E1, which is a potent vasodilator which can help in decreasing the platelet aggregation and decreasing the neutrophil activation, ibuprofen, which is an inhibitor of cyclooxygenase pathway, ketoconazole, which is a potent inhibitor of thromboxane and leukotriene synthesis, pentoxifylline being a phosphodiesterase inhibitor, lisofylline and anti-interleukin 8 therapy. Some other treatment options would include salmeterol, which is a lipid soluble beta 2 agonist, intraalveolar use of terbutaline, dobutamine, which is a beta 2 adrenergic agonist, and dopamine at a dose of 5 microgram per kg per minute can increase the alveolar fluid clearance in an isolated, this study has been done in isolated perfused rat modules. Other research options that are going on are the studies of hepatocyte growth factor and keratinocyte growth factors. Coming over to complications of ARDS. Now, ARDS can lead to many complications. The first and foremost is the pulmonary complications, that is number 1 barotrauma, pulmonary embolism, pulmonary fibrosis and ventilator associated pneumonia. The GI complications of ARDS would include hemorrhage or ulcers, dysmotility, pneumoperitoneum and bacterial translocation. Cardiac complications include arrhythmia and myocardial dysfunction. Renal complications include acute renal failure and a positive fluid balance. Mechanical complications due to ventilator can be vascular injuries, pneumothorax by placing a pulmonary artery catheter, tracheal injury or stenosis as a result of prolonged intubation or irritation by the endotracheal tube. Nutritional complications would include malnutrition due to a catabolic state and electrolyte deficiencies. What are the weaning protocols from a ventilator in patients of ARDS? So, whenever your FiO2 requirement is less than 0.4 and when the PEEP of the patient has been reduced to 8, then a daily CPAP breathing trial should be given to the patient when the patient has acceptable spontaneous breaths and the patient is out of shock, that is no vasopressor requirement is there. When weaning the patient, the pressure support should also be weaned, that is a PEEP of 5 and a pressure support of less than 5 centimeters of water when the respiratory rate of the patient is less than 25 per minute. However, if the respiratory rate increases, then the weaning should be withheld. Whenever there is an unassisted breathing, that is the patient tolerates a TP strain or a track collar for 30 minutes to 2 hours, then extubation can be considered. How do we know that the patient is tolerating the breathing trial? That is, the patient is maintaining a saturation of more than 90. Patient has a spontaneous tidal volume of more than 4 ml per kg body weight of the predicted body weight. When the respiratory rate is less than 35 per minute and the pH of the patient is more than 7.3. During the weaning trials, the patient should have no respiratory distress, that is out of these 5 features, the patient should have at least 2 or more. Whenever the heart rate is goes to more than 120% of the baseline, if there is use of accessory muscles, if there is abdominal paradox, if there is diaphoresis or if there is marked dyspnea, then the weaning should be withheld. However, if any of these features are not present and the patient tolerates these weaning trials for more than 2 hours or so, then extubation should be considered. To summarize, first of all, when weaning, the patient's predicted body weight should be taken into consideration. Not the ideal body weight, but the predicted body weight of men should be 50 plus 2.3 into height in inches minus 60. For females, the predicted body weight is calculated as 45.5 plus 2.3 into height in inches minus 60. The tidal volume in the ventilator should be 6 ml per kg body weight of the predicted body weight. The initial rate in the ventilator should be set at the baseline minute ventilation. The FiO2 and the PEEP should be set to obtain a saturation level of more than 88 to 94%. Diuresis should be started after resolution of shock. This is to summarize the mechanical ventilation according to the NIH ARDS network protocols. The tidal volume of less than 6 ml per kg body weight should be maintained. The goal to maintain a plateau pressure should be less than 30 centimeters of water. The ventilatory rate should be set between 6 to 35 per minute to achieve a pH of more than 7.3. The IE ratio should be maintained between 1:1 to 1:3. The oxygenation goal should be to maintain a PaO2 of more than equal to 55 to 80, and the saturation goal should be 88% to 94%. We have already discussed the FiO2 to PEEP sliding scale, and the weaning of the patient should be started when the FiO2 requirement is less than 0.4, PEEP requirement is less than 8, with a pressure support ventilation of less than 5. Coming over to troubleshooting of common problems. Whenever the plateau pressures of the patient are more than 30 millimeters of mercury, then we should decrease the tidal volume by 1 ml per kg body weight to as low as 4 ml per kg body weight. We should also rule out any chances of pneumothorax, auto PEEP or other reasons for acute change in the compliance of the lungs. Sometimes the patient also has a dyssynchrony with the ventilator. That is, if the P plat is less than 30, then we can increase the tidal volume by 1 ml per kg body weight to as much as 8 ml per kg body weight, ensuring that the P plat is maintained to less than 30. We can also increase the inspiratory flow rate. The sedatives and paralyzing agents can be used if the patient has hypoxia. If the patient has hypotension, then we should initially give volume to the patient. We should ensure that patient has not developed any pneumothorax. We should also evaluate for auto PEEP, and we should minimize sedation in such patients. If the pH of the patient is less than 7.3, then we should increase the minute ventilation, and if the pH is less than 7.15, then we should consider the use of soda bicarb therapy. Sometimes the patients of ARDS have refractory hypoxia. In such cases, we should first rule out any mechanical cause of hypoxia, that is the tube is kinked, or there is some mucus plug, there is any kind of pneumothorax or any ventilatory settings that are hampering the oxygenation. Second is, we should give neuromuscular blocking agents to this patient. Third is the recruitment maneuvers. The prone positioning should be given to these patients so as to decrease the ventilation perfusion mismatch, increasing the PEEP to an optimal PEEP, and the use of high frequency ventilator. One of the studies was also published in the year 2013, which was on the use of high frequency oscillation in early ARDS. This study was given by Ferguson and et al. This was a randomized controlled trial in 1200 patients. In this study, they concluded that early initiation of HFOB did not decrease the mortality in the patients. However, it had increased the hospital mortality. Another study, which was published by Young and et al. In the year 2013, was also a multicentric randomized controlled trial in 795 patients. They also found that use of HFOB had no significant effect on 30-day survival between patients who received HFOB and conventional mechanical ventilation. Again, Papazian L et al. Had published a study in 2010 for the use of neuromuscular blocking agents. In this study, they had concluded that neuromuscular blocking agents may increase oxygenation and decrease the ventilator associated lung injury in patients with severe ARDS. This was a multi-center double-blind trial in which 340 patients were taken and they had received 48 hours of cisatracurium. In the study, they had found that use of neuromuscular blocking agents improved the 90-day survival and increased the time of ventilator without increase in neuromuscular weakness. Other supportive therapies in patients of ARDS include treating the underlying infection, deep vein thrombosis or the stress ulcer prevention, proper hand washing technique using full barriers, proper sedation and analgesia, using feeding protocols, using contrast nephropathies and avoiding the use of steroids. Ultimate solution, the use of veno-venous or the veno-arterial ECMOs still needs some trial. Conclusion, the recovery of the patient is in ARDS is mainly dependent on the health of the patient prior to onset. Within 6 months, the maximum recovery will be reached in patients of ARDS. At 1 year post extubation, more than 1/3 of the patients of ARDS would have a normal spirometry. However, the ARDS survivors have significant burden on emotional and depressive symptoms, and these patients often land up into post-traumatic stress syndrome. Newer treatment modalities and lung protective ventilation strategies are still into consideration. Thank you.